So welcome everyone, and thank you for making time to be here with us today for the Central Oregon Health Council meeting. And I'd like to go ahead and start off with introductions, and I will just go ahead and go through the screen if that's all right. And so Donna, you are in pole position.
Well, let's make sure I don't echo here really quick. Hi, everybody. Donna Mills, Executive Director for the Central Oregon Health Council. My pronouns are she, her, and hers.
Excellent. Camille.
I'm Camille Smith. I am the admin at the Central Oregon Health Council.
Wonderful. And thank you for keeping us organized. Rick.
I'm Rick Trelevin. I'm a licensed clinical social worker and CEO of Best Care Treatment Services.
Wonderful. Gary.
Good afternoon, Gary Allen, Vice President, Clinical Services, Advantage Dental.
Wonderful to see you. Brad.
Everyone, Brad Porterfield, CAC member, consumer rep chair, and also director of Latino Community Association.
Wonderful. Had a chance to visit your facility. Really beautiful. Yes. Dan.
Hey everyone, Dan Stevens with Pacific Source. Good to see you all again.
Good to see you. Linda, partner in crime.
Linda Johnson, community rep for the Health Council, adjective she, her, and hers. Pronouns, rather.
Wonderful. Thank you. Iman, great to see you.
Hi, good afternoon. Iman Simmons, and I serve as St. Charles's Chief Operating Officer.
Wonderful. Rebecca.
Rebecca Donnell, Innovator Agent with the Oregon Health Authority, pronoun she, her, hers.
And on the agenda in just a few. So we'll save the drum roll. Michaela.
Hello, Michaela Arsenault, Project Manager with the Health Council, she, her, hers.
Thank you. Leslie.
Hi, Leslie Neugebauer from Pacific Source.
Hello. Trisha.
Hello, Trisha Wilder, she, her, and hers from Pacific Source as well.
Wonderful. Renee.
Hi, everyone. Renee Worth, Project Manager with Central Oregon Health Council.
Excellent. Gwen.
Gwen Jones, she, her, hers, Project Manager as well.
Excellent. Kristen.
Kristen Tobias, she, her, hers, Community Health Coordinator for Pacific Source.
Excellent. Kat.
Hi, Kat Mastrangelo, Executive Director at Volunteers in Medicine and member of OPS.
And Kristen, I continue to want to call you Kirsten because I have a Kirsten. And so can I just rename you just for, I'm kidding. My apologies.
It's totally okay.
I'm consistent in my, my
See,
apologies.
now I have an ear out for it.
Oh, I love it. Oh, good. I should have a jar and we'll make it for donations and I'll give it to Brad's organization for every time I get it wrong. All right, Wendy Jackson.
Hi, everyone. It's Wendy Jackson, Chief Operating Officer for Central Oregon Pediatric Associates. Good to see everyone.
Good to see you as well. Erin.
Good afternoon, Erin Fair-Taylor, Vice President of Medicaid at Pacific Source, and I'm just going to be off camera a little bit more as I finish my lunch.
Not a worry. Thank you for being here. And I have a phone number that ends in 9028. If you'd like to introduce yourself. Okay. It's probably the governor just, tracking what we have going. I'm kidding. Okay, so who did I miss? Okay, so Donna, I will, I think that is it for introductions. Unless I've missed someone, please go ahead and jump in right now. All right, so next we have the action item, which is the consent agenda and the approval of the agenda. Is there anything in the consent agenda that anyone would like to bring forward or that you have questions on? If not, I would welcome a motion.
Tammy, you don't have a quorum, so.
Oh, okay, right. Okay.
Yeah,
all right.
You need to jump over the consent agenda for now.
Not a worry. Excellent. Well, we'll get to one of the most important parts of the meeting, which is the patient story. So I will turn it over to Brad.
Trying to get there, trying to multitasking over here. Thanks, Tammy. So the patient story today is not actually a patient story, but it's we wanted to share with you all as follow-up to two of our patient stories, one about periodontal care and one about pediatric dental care. The CAC Community Advisory Council has moved forward and invited the dental care organizations, our 3 dental care organizations, to meet with us. And so next week at our CAC meeting, we'll be meeting with representatives of the 3 dental care organizations for our region and some other people. There's some other people as well. And to just have a conversation, kind of build relationship, understand better, how the DCOs operate. And we have couple specific questions for them, and then we'll be sharing those patient stories with them at that meeting. So we're excited about that. It's just bringing us closer together, understanding better, and sharing those stories directly with our DCOs. Looking forward to it. Just want to share that, make sure the board's aware.
But I think that's really powerful, because hearing where things are not going well when their intention is to do their very best is difficult, because we know that we're not going to be able, the system isn't perfect, no matter how much we're trying and how many hours we're putting in. And I just really appreciate the fact of the openness, the ability to have that communication feedback loop, the ability to develop relationships and really inform how the care is either working or not. And really want to thank you for your leadership in that and carrying that forward, but also looking at it in a way that is how we get to success, which is the ability to work through some of these challenges and finally remove the barriers that have been there for so long. So thank you to you and to Gary and his team, and just to the DCO folks that are willing to come together and have that chat.
Yeah, and if I could comment, I'm, I guess fortunately or unfortunately because I won't be able to participate, but fortunately I'm going to be on vacation next week. But I have, we've mobilized a couple of folks from our plan, vice president of our plan operations, and also vice president of our practices, which is probably better because, I've heard the patient stories and I've shared the patient stories, but I think it's going to be good for them to hear firsthand from the folks that have been working this issue as well. So apologies, I won't be there, but I think you're going to have a good team from Advantage Dental.
Thanks, Gary. That's all I got.
Okay, well, that's a lot. So thank you for the added investment of time there as well. And Gary, enjoy your vacation. So next we have the Joint Management Agreement 101. And so Donna, shall I turn it over to you and Tricia?
Yes, that would be amazing. And thank you for the slide driver, folks. I believe, and Leslie, you can keep me honest here, but I think Leslie and I started a couple of years ago, in 2020, of course, is the big COVID blur, to bring forward once a year just an overview of our joint management agreement and the governance structure of the board. You can go to the next slide. And Tricia, you just jump in here and help anytime you want. I know you have a burning desire to give this presentation today, but you were kind enough to give it to me. As you might recognize, the board hydraulics document that was prepared a few meetings back, and the board has asked that we continue to put it in the packet, but I also wanted to make sure that we called it out here, because the things that to me resonate as important to the community is that our board uses a hybrid distributed leadership model, which means that all the decisions aren't made up here at the board level, but actually in the community. Your health council staff, we operate just as the workforce behind the scenes, if you will, but we really do look to the community to actually make those decisions and to really ultimately point those public dollars where they need to go, which is extremely important, right? But what the board is responsible for and has signed on for is the 3 pillars of the strategic plan, which are the governance of the CCO, of course, long-term systemic change, and then the RAW and the RIP. So you can go to the next slide. Great. So having said that, what is the joint management agreement? And again, for some of us, when we're in it every day, it seems very natural, but when you're not, I think it's really important to come back and ground the board back to, what you are empowering your health council and your community to do. The joint management agreement is a contract between Pacific Source, our CCO, and the Health Council. You can go to the next slide. What is the construct, or why did we have to have that? Back in the day before we were actually born as the Health Council, we had all kinds of different names. And all of that historic context, by the way, is on our website if anybody needs some light reading. Tammy Bainey is in there quite a bit, by the way, I would have mentioned, she just keeps coming around. The JMA really was groundbreaking around this community governance model that was also supported by legislation. And if I'm not mistaken, the first bill was 204. We're up to 741. We're just growing right along. But what that afforded the community was to, one, work as a region instead of working as individual counties, which proved very important. And it also allowed for this governance where there could be a community arm of the CCO. So that's the oversight piece of really following that strategic direction and transparency with the CCO, so that we could be transparent to the community. And of course, the collaboration, and that word gets thrown around a lot. These days, I like to hold it out as something that recognizes that we aren't always going to be serving ourselves. We're going to be serving each other and serving the community if we're doing it right. So next slide, please. Great. And Tricia, if you want to jump in here, that's, anytime you just say, hey, Donna, quiet for a minute. So what are the provisions of the JMA? One of the things that we really do like to call out is that the contract between the CCO and the providers is outside of the JMA. It doesn't play any bearing into our business model. And it really is separate and completely autonomous from the Health Council. The joint management agreement, of course, as you can see here, it provides for 0.325% of each Medicaid dollar to come to the Health Council to keep our lights on and to pay our phenomenal staff. Then the 1% is the Regional Health Improvement Plan investment, and that is also of the whole that we receive on a monthly basis. We don't internalize any of those dollars. Those are immediately turned around and pushed back out to the community, supporting the RAW and the REP. And they also have to be spent by the end of first quarter of the following year. So anything we were to receive for this month relative to the 1% RIP investment must be spent out the door according to all the rules by March 31st of 2023. The other piece of the JMA that's really important is that the Health Council agrees to ensure a 2% margin for the CCO. Now, I might want to mention here is that the CCO has never changed that since the inception of the JMA. It's always been 2%. They've never increased it. They've never increased the admin costs. And I think that really depicts their commitment to the community. So now we'll pop over into the other side, which is at the end of the year, what happens at COHC? So again, we talked about that 0.325 being our operating revenue, and we're running pretty close. We do produce a little bit of a surplus, but as we grow, it's less and less of a surplus. If the CCO budget receives their 2% margin and there is still surplus in the CCO, then 50% goes into behavioral health and 50% goes into direct payments back to COHC, 1%, CCO 2%, and the balance is distributed to our providers in our health system. If there's not a 2% margin, i.e. 2020 and 2021, then there is something called a recapture. And if you were with us in the February meeting, you might recall Justin from Pacific Source sharing with us that there was a $4.7 million recapture that was due back to the CCO. And in the same meeting, Aaron was able to share with us that once again, the CCO had forgiven that recapture, and hence those dollars would be able to flow into the community. And I just can't say thank you enough for that, because I'm not going to say the Health Council would have to scramble, because we've done a really good job of being prudent with our funds, and we would have been able to both facilitate taking care of the community as we are charged with, as well as making up that recapture. But the fact is we don't have to now, and now we can continue to put those dollars back into play into your community to really move the metrics that you all decided were the most important in the RIP. So I'm going to take a breath and see if Tricia has anything to add.
I just think in this space, first of all, Donna, I mean, you're incredible at this. This is not your first rodeo. And, but I think it's interesting to know that our model is unique in Central Oregon, and also that there are 15 total CCOs in the state, and Pacific Source oversees 4 of those CCOs. And we also have an independent delivery system in the Portland area. So that's a unique relationship with Legacy. So I just think that, you know, this model is, although we are the first, and I think we are incredibly innovative, is not exactly replicated across the state. So you all are really part of something truly unique and innovative.
Thanks, Tricia. The next slide, which I love because Camille found this slide and it actually looks like me from behind.
Hey, Donna.
Yes, Dan.
I was just maybe just a minor language thing on the previous slide.
Of course.
Appreciate kind of the call out to the uniqueness of the model and the forgiveness of recapture. We were happy to do that. But the one thing that probably isn't quite accurate is the left side of the previous slide where it says ensures a 2% margin. It kind of makes it sound like we have no downside in this. And that probably is a word that we should think about in the future as we communicate this out to broader audiences. I know we're always doing some level of education on how the CCO governance works. So if the CCO doesn't make a 2% margin in 1 year, the Health Council could, I suppose, write a check right away and say, here's recapture. But it was really designed to say in a future year, if we make in excess of a 2% margin, the first call on those dollars is the recapture, as opposed to Health Council just has to make us whole.
Yeah, I think that, I mean, you're correct. Justin and I have this conversation probably 2 or 3 times a year, because the insurers is a strange word to use, because Justin's always, well, you don't have to pay it back right now. You can just pay it back over time, right? And in my accounting brain, no, we have cash. We're paying it back right now. So totally understand that. Thank you for pointing that out.
Yeah, it was probably the difference between what the actual JMA stipulates and kind of a preference. But we would never require that. We would want to follow the JMA. So not to confuse folks, because it does get kind of detailed, but that's just something that's probably important for consistency of education and such. Other than that, awesome job describing this, because it's complicated.
Yeah, for sure. For sure. Thanks, Dan. Appreciate it.
Hey, Dan, while your mic is still open, one of my favorite pieces of my onboarding has been some of your talking about what the secret sauce is in this space. And I'm wondering if you would like to share that with the group here, because I think it's an important point.
Now I have to remember what I told you in your onboarding.
Look at Leslie.
It's mostly just because I always say, as Dan says, the secret sauce of
No,
the
I think, I
health
mean,
council is.
and I think so many of us know this, but if I talk to somebody on the street about it, or apparently a new employee, you know, I mean, one of the things that became evident early on, and it is by no means perfect, and we are by no means perfect in this, right? But one of the things that became evident early on, and Tammy could jump in here too, and others that have been around in this for a while is, and Rick, is the way that this was constructed. There was a noticeable shift such that when there were objectives that came from the state, that the CCO is, you know, according to our contract with the state, we're the single point of accountability. And what's so common in our healthcare system is if it's a health plan or a health insurance company metric, and we run out to providers and we run out to the community and say, help us with these metrics, and maybe we can throw some dollars on them if we hit them. The dynamic really kind of changed because we got to sit in rooms like this and like ops and like the provider engagement panel and CAC and say, here are the metrics, here are the expectations, here's where care gets improved if we do these things, care to beneficiaries, lives can be improved. And we're all in this together with respect to how the dollars flow in a really transparent way if we hit these. So, you know, we used to kind of joke, hey, it's $1 million per QIM, you know, per each QIM metric that we hit. And it was evident as we created this that people kind of understood, hey, that doesn't mean it's $1 million to Pacific Source. That's our money collectively. So is it perfect? No. Should we keep tweaking it? Absolutely. But it is pretty unique. It is pretty unique to have an insurance company, to have people tell an insurance company, hey, we kind of feel like these are our metrics, not just yours, that you're asking us to do something for. So.
Really well stated. Okay, so Donna, anything else that you want to add?
Nope, but you have a quorum.
Okay, very good. Well, let's go back to our consent agenda. And if there isn't anything that anyone would like to remove or have further discussion on, I would welcome a motion.
Ms. Gary Allen, I'll move to approve the consent agenda.
Excellent. And a second?
This is
This is
Linda.
Iman.
I'll second.
Oh, I defer to Linda.
Okay, so Linda, we have a second. Okay, any further discussion? All right, all those, how about we go with anyone opposed? So we don't step on each other. And hi, Justin, wonderful to see you. Thank you for joining us. Okay, I'm not hearing anything from anyone. So anyone opposed? Motion carries. All right, thank you. So next, let's go to, I'd like to welcome Justin, as well as it looks like Mike Shercliffe has joined us. Not sure if he's still hanging with Alvin and the Chipmunks, but just wanted to make sure that you know that we see you. Next is the CCO initiatives, and I'm going to just tee this up a little bit with, you know, we are in the Tri-County area experiencing a public health crisis, and that is the situation with the individuals that are unhoused in our communities. And as you might all imagine, it is different as you go from community to community, county to county, city to city. But certainly in an area in which I, for one person, have just wondered, well, where is the table for us to maybe be talking about this a little bit deeper? And I've received a few questions of what is the role of the Health Council in this discussion? And maybe even most importantly, what are others doing that maybe we can take a page from their playbook on? And are there things that we could be doing right now that maybe we're not doing? So this is a tee up to that conversation. And the other piece to this is, as you were hearing the presentation, the question for all of you that are on the Central Oregon Health Council board is that, do we need to maybe be looking at an ad hoc committee, or do we need additional information that we'd like to bring forward? Or what really would you like to do after we hear a couple of the cool things that are happening across the state with this conversation and in this space. So there is a little bit of guidance that I'll be looking for at the end of the conversation. And with that, I'm going to turn it over to the Rebeccas. Now, Rebecca, are you on your own? Are you flying solo today?
I'm not flying solo. I think my partner, Rebecca Alvarez Knight, is on a pretty tight timeline, and her window was 1:10.
Okay.
And so, but I have a little bit to get us started before she's going to do her piece. And so I think this will work out perfectly. I'll kind of share some of the other info, and then when my partner, Rebecca Alvarez Knight, joins, she'll go on a deep dive into one of the areas that I shared with the board in the update. So I think this will work out fine.
Excellent. We will roll with it. So the floor is yours.
I appreciate the flexibility in case Rebecca's a little bit delayed. But hello, everyone. I'm Rebecca Donnell, pronoun she, her, hers, and I'm an innovator agent with the Oregon Health Authority. And as Tammy, what a great intro to this, Tammy. Thank you for that. Described a few months ago, the board was talking, as I think everyone in Oregon is talking about, what's going on with COVID and homelessness, and in particular, that intersection between COVID and homelessness and the public health crisis we're experiencing, and thinking about what does it mean to be homeless right now, and how does that impact individuals and their ability to take care of their health, to access health care. What does it mean to seek employment? What does it mean to need and look for housing or experience food insecurity and need to be looking for food resources? And what can we be doing as a community? What should we be doing? How can the CCO help support identifying and connecting people to resources? And, the intersection is a pretty big question. So I did say during that meeting, I don't have specific information to share, but I'd be happy to go back and connect with others at the Oregon Health Authority and see what other CCOs are doing, what other organizations are doing, and try to bring some of those examples forward to the board. And so I think I summarized those for you, and Camille shared them out, I believe, to the board in your packet. Rebecca Alvarez Knight is going to share with you a real deep dive on one of the areas that I found when I was talking with folks across the Oregon Health Authority and in the Transformation Center. I'm going to summarize more briefly for you some of the other ones that I found across the state. So with that, any questions before I get started? Okay. The first example that I found was from All Care and All Care CCO, and they had established a COVID-19 resiliency fund. And the fund was meant to rapidly deploy funds to community-based organizations to get money into the community where it was most needed, and to really be a low barrier way to allow organizations to access funds as they need them. They developed the fund to respond to social determinants of health and equity issues in the counties that they serve, which are Curry, Jackson, Josephine, and Southern Douglas counties. And specifically, they streamlined applications and heightened priority for certain populations, and specifically those communities that were impacted by domestic violence, economic fragility, families, youth, and children, food insecurity, homelessness, and those in marginalized housing, and members of the Latinx and tribal communities, folks with underlying health conditions, senior citizens, and non-elderly disabled adults and veterans. And so for those folks, they provided an even more easily facilitated, rapid, expedited application process for folks to try to rapidly get funds out into the community to address needs. So that's one example of a way that folks were trying to connect the dots for people in terms of being impacted by COVID and having social determinants of health factors that were making people more vulnerable. The next example that I found was from HealthShare of Oregon, and it was COVID-19 provider continuity. And in this example, the health systems that are part of HealthShare have both commercial health plans as well as administer Medicaid for the state and OHP. And what their aim was is to reduce disruption for individuals who moved from a commercial plan to Medicaid and to allow them to maintain their provider. So if I was enrolled in a Providence commercial plan or a Kaiser commercial plan, and my economic situation changed within my family, and I applied and was accepted to OHP, the idea was that they could continue on with Providence or Kaiser on a Medicaid plan and be allowed to see their same provider, so that there was no disruption to families seeking care. And so for each of these examples, I have specific follow-up contact information. So if you're interested in any of these examples, I can connect members of the board or health council staff to others to come and speak with the board or just to gather more information. So the next example is also with HealthShare of Oregon, and it was just enhancing capacity to use Medicaid flexible service dollars and to really kind of look at ways that they could work with partners specifically around food insecurity, looking at folks around community-based organization and making sure that they knew how to access those flexible spending funds. And that's really all I have on that one. And then in Eastern Oregon, there was HRS COVID-19 funding for unanticipated needs. So Eastern Oregon CCO using health-related services funding to assist individuals with COVID-19 unanticipated needs, such as living arrangement disruptions. So those are just a few examples, working with the Health Transformation Center at OHA to look at what other CCOs had reported doing around social determinants of health and COVID, and to try to find some intersection with the question that the board had asked. There are some innovative ideas there, particularly I think the resiliency fund and the provider continuity are really interesting responses to what folks are experiencing. I also want to talk about, and Rebecca Alvarez will be joining me here shortly, one of the most interesting examples I found during my research, which was how OHA is using Z codes within the EMR to identify folks who are unhoused, and we can look at whether or not those folks have been vaccinated or remain unvaccinated, and how we might do outreach to increase vaccination rates. But there are so many implications for how Z codes can help us identify folks that are unhoused and how we can better connect them to different resources, food security resources, housing resources, behavioral health. So as Rebecca shares what she's been doing at OHA, specifically around COVID and the unhoused, you can be thinking about it for broader applications. So how these Z codes, and if we entered the Z code information that allows us to identify unhoused individuals, how we could then connect them to other resources in the community. And I'm hoping Rebecca has joined. There she is. Perfect timing. I'm going to hand it over to Rebecca Knight Alvarez. She is a operations and policy analyst at OHA, working in the COVID response and recovery unit, also works with behavioral health, and I think has a couple of other additional hats that she wears. But Rebecca, I'm going to hand it over to you for time's sake to go deeper into what you've been doing with Z codes.
I'm here, I promise. My mute button went up when I went to share with you guys. Yes, I'm Rebecca Knight Alvarez. My pronouns are she, her, hers. I'm coming off of the COVID response and recovery unit. I had multiple hats and things in that, and that's where this project started. Currently, I'm in Health Systems Division at OHA and the Medicaid and Policy and Planning team as a behavioral health special projects coordinator. It means I get all kinds of random special projects to help, like stand up or help figure out, all of those kind of things. I'm still also in the incident management team for the behavioral health Omicron surge. Those are some of the examples of things that I'm working on. And I'll try to only talk 10 minutes about this topic. I could talk to you guys for much longer, and I am more than welcome to come back and like dig deeper because Rebecca has seen a longer version of this with the same amount of slides where I actually talked to their team for an hour and a half to really help them understand what I was doing and why. And so I'm going to tell you that as I start talking. But the purpose of this conversation, we're going to talk about people experiencing houselessness. I gave you some of the common complicated word uses that we might hear in our communities to help you understand that. And I'm also going to give you a caveat that I'm mostly using adult definitions. We would have to have a little bit longer conversation to talk about definitions around children and youth. They have a more broad definition of what people experiencing houselessness are. And in this, I'm going to use people experiencing houselessness or families experiencing houselessness as I discuss with you today, even though I know unhoused, homelessness are all common words in our communities. I just am going to continue to use people experiencing houselessness because our housing advocates tell me that's the most appropriate use of the word. But homeless in the terms is any individual who has no permanent living arrangement, no fixed place or residence is considered homeless or transient. And then it gets a little bit more complex on what is houseless. And these are the HUD definitions of houselessness. Is any individual or family who lacks a fixed, regular, and adequate nighttime residence, such as those living in emergency shelters, transitional housing, or places not meant for habitation. It also means a person that hasn't had a place to live within the last 14 days. It could also be our unaccompanied youth under the age of 25. And at the Oregon Department of Human Services, they actually changed the words around our youth. And so if you haven't seen, there's also some new language around that. And it could be an individual or family who's also fleeing or domestic violence. And so those are the specific definitions for this population we're going to talk about really quick. And so I was given the task to help mitigate COVID for people experiencing houselessness all of last year, and to really help ensure that they were getting accesses to vaccine and testing. And so vaccine equity for people experiencing houselessness really helps increase a person's risk of contracting it. It also helps trying to make sure that they don't become ill, but because they typically live in crowded living conditions and shelters, social distancing and hand washing can be difficult. And through the beginning of the pandemic, some of our typical places where people could wash their hands, like the library or fast food place, they shut down public use. And so really hand washing became really difficult for some of our community members. We also just want to make sure that they have every opportunity to get a vaccine and help protecting them and the public and safeguarding the health of the vulnerability they have living in our communities. And many of them have other chronic illnesses such as cancer, lung disease, diabetes, or behavioral health conditions that could interfere with interventions and masking. And so when we're talking about vaccine, it's really important to try to decrease the barriers and help them with testing and getting vaccine. And so we do not have a robust system or any type of information system that tracks every person experiencing houselessness in our state. So I'm going to say that just to be honest. So when I was starting out doing this work, people would ask me what was our vaccine rates for people experiencing houselessness, for how did I know if I was making a difference? How did I know if the counties or the local partners were getting to these really vulnerable populations? And I am lucky that I had worked in the Medicaid behavioral health team and knew that there were these diagnosis codes related to houselessness in our Medicaid data. Otherwise, I don't know how I would get any answers for anybody on vaccine efforts for people experiencing houselessness throughout our state. But in our diagnosis codes, there are particular codes that we could use, and they can be used in behavioral health. They can be used at the ED level. They could be used in primary care. And these are the particular codes that could be put in for any billings cycle within the year. And for me to be able to use them, a provider's had to input them in the system with a client visit and code them with these particular codes. And so Z590 is homelessness, and Z591 is inadequate housing. Z592 is discords with their neighbors, lodgers, landlords. Z593 is problems related to living in a residential institution. Z598 are other problems related to housing and economic circumstances. And Z599 are problems related to housing and economic circumstances, and unspecifically problems related to housing or economic circumstances. And so because we don't have information system right now or a way to like really figure out who is experiencing houselessness or is experiencing some instability with houselessness, this was my best shot at trying to get vaccine data and tracking it. And I track it every month. And so I'm also sharing these codes with you guys in case you didn't know they existed. And now you know that your CCOs can use codes like this and your providers can use codes like this to look at different ways of health. And so I will share my slides back and you guys can have them all and be able to think of more creative ways than I did on using these codes and how they might be able to be used in your community. And so I'm going to give you just a random time period that I pulled the vaccine data. And this isn't all of what I look at, but it would take us a lot longer to be able to explain what I look at every month when I'm looking at the data. But for the year of 2021, anybody who has used these codes have been, and they'll come up as these sums of the number of recipients. And each one of these lines is actually a different CCO. And so it's broken down by CCO, a number of person that's been identified in the system with one of those Z codes. And then then this was for the month of October. So any data from January to October was pulled to look at this, or at this snapshot in time. So again, these are the number of people who've been coded. These are actually the number of people who got vaccinated in any month from March, because that's when they were eligible, or before in December, to October by that CCO, and then what was their percentage from this number over. And so by CCO, that is what I look at. And I also now am looking at booster data, second doses. I also look at it by race and ethnicity, by regions, counties, and CCOs to give you a bigger and more clear snapshot of what I look at. And so I could pause if you want to look really quick at how many people have been identified by a provider throughout the state as experiencing houselessness in 2021. These were the number of people so far that have got vaccinated from this total and the percentage. And so to be more honest and transparent, I'll go to the next slide. And so we know this isn't accurate, that not all providers have the ability or know about these Z codes or utilize these Z codes, or we also know that they're not always used with visits. So some people might not be identified because providers haven't been having these technical conversations, or they're being coded a different way. There's all kinds of things, but I was advised to give you 3 examples. And so with CCO number 1, these are the number of people identified by diagnosis codes for their area. And from their same point in time count that I pulled, these are the differences. So somehow either these 1,428 people haven't been to the primary care or behavioral health care in the last year, or they just haven't been coded in their community. And this is just the people who are like living on the street from their point in time count in their region. And so here's CCO number 2. These are also the people who have been identified by their CCO providers. And then these are all the people that were recognized by their community action agencies and partners with their point time count. And then CCO number 3, these are actually the individuals that were identified by the diagnosis Z codes. And then these were the ones that were identified by the point time count. And this particular CCO has been working on having these conversations with their members when they're coming in. And so they're actually identifying more people than the point time count are doing. And so throughout the state, there's varied usage of Z codes and how they're using them throughout. And also how I've had my very last slide, not this one, is we'll talk a little bit about barriers if we make it to, because I know I'm almost out of time. And so why is this important? Being able to use these Z codes is a great way for us to capture the work we're doing with this population. It also incentives and equity metrics are coming, and we do have currently a Medicaid 1115 waiver application put in. We haven't been awarded around trying to come up with like housing supports. And one of the questions I was asked was, would this be able to help the CCOs like track the work that they're doing, and what kind of system would we need to do? And so they were asking very technical questions to be able to like show and provide examples of the work that's already being done and being tracked. And so we know that right now incentive measures are already there and equity measures are there, but more might be coming. In the context of this conversation, it's also helping to mitigate the spread of COVID for our population. It also provides transparency and integrity with our Medicaid data, and also allows us to track more effectively on how we're reaching priority populations. And in this example, it's for people experiencing houselessness, and how we can track it year by year on how we're linking them to different services, or looking at a particular health disparity or resilience factor. And that's why all this work is so important if we're able to utilize it and use it throughout the whole state. And so other ideas of utilizations for these codes that you guys could think of, and there's way more than I listed, is I don't know if you've heard, but redetermination of OHP is going to happen, and getting ahead of it and trying to have these conversations with our community members and identifying them ahead of time and providing assistance with their application renewal process will really help with redetermination. Trying to get more updated addresses and phone numbers are critical. Utilization with childhood vaccines. Unfortunately, there are children who are experiencing houselessness, but making sure that they're getting access and decreasing barriers for their childhood vaccines. So it could be used for other vaccines and not just COVID. It could Z codes could be used for primary care access versus emergency department utilization. So making sure that they're not just using the ED, but we're getting them linked to primary care, and primary care is trying to help and manage their care outside of the emergency department. It can also help with prescribing. So if a person is experiencing houselessness, having that conversation on, I don't have a refrigerator. I can't store penicillin in the fridge for my child's ear infection, and making sure that we're getting them the proper medication for what they need. Insulin is another one where we know that prescribing is so important. But there's so many other ways that these Z codes could be used creatively in your community. These are just some that I've thought of and can ramble off in a very short amount of time. And the last one, I did ask some of the CCOs in a previous meeting in December, what were some of the barriers to using these? Some of it said is basic things like staffing issues. We don't have enough staff right now to think about taking on another code. Some of them said that they don't know if their providers are using these or aware of them, so they would have to figure that out. There's also individuals are not coming in for care in the last year. They don't know why. Some of them are using a different internal system of monitoring housing and health, and some of them aren't screening or asking that question. Some of them felt they needed more training and technical assistance, but there's often others that I just don't know about. And that's what I have. And if you have questions, I can pause and answer. But thank you for listening to me today.
Wow, thank you very much. Donna, it looks like Donna has her hand up. Okay, go right ahead.
I have two questions. The first one, Rebecca Donnell, when you were talking about the resiliency fund, did that have a dollar cap on it per grantee?
I'm sure it did, but I don't know what that is, Donna, but I can find out. Why don't I get you the contact information and share that with you?
That would be great, because I just wondered if it was aligned with the mini grant program that we did. I'm sure that you're aware of, but happy to talk with you about that further. And then I'm an equal opportunity Rebecca questioner. So other Rebecca, thank you so much for your presentation as well. When you're looking at those Z codes compared to the point in time count, are those unique Z codes, unique patient codes, or could that have been, I presented today and they recorded my Z code, and I present next week and they record my Z code again?
So I'll give you two things, because there's two caveats to your question. So they are unique individual Z codes per that individual. And so yes, they could have been coded multiple times throughout the year, but we only pull and look at it for once. So for instance, if Rebecca Knight Alvarez, was experiencing houselessness and my provider coded me as that, and then I got my 2 Pfizer vaccine doses, I only come up once in my data pool. The other thing is the people identified in the point in time count and the people I see I don't see anybody's names. And so when I get it from the data analyst, I just see number counts. And so we are not sharing that level of detail, and we don't have data sharing agreements with the Oregon Housing and Consumer Supports, who oversees our community action agencies. So at this time, if they have members who are experiencing houselessness and they don't have OHP, we don't even know that. And so we're having those kind of conversations on like how to improve data sharing, even with our state agencies, because I don't even know who their 1,428 people are versus the 400 that might be on one line item, if that makes sense, Donna.
Yeah, it does. Thank you, Rebecca. And unfortunately, that makes me ask another question, but it would be really interesting to me. I actually know providers are using Z codes here in Central Oregon, although I don't know who they are or whether they're being consistent. So that, I know you are the master of small little projects, so I'm thinking maybe that might be one that you could talk to me about. Thank you so much.
Gary, dive in.
Yes, thank you, Rebecca. And Rebecca, great presentations and a very important and complicated subject. But I'm curious, you know, you've been gathering this data for a while, and you're obviously looking at it and kind of dissecting it, mulling it over. But what else is done with this data? One of the obstacles that you mentioned was just a lack of awareness of the Z codes. And I kind of wonder if that's partly because we're not getting this information out, if it's all just being housed with you, or is anybody else, interested in this? I mean, we're certainly interested, but this is, the first I've heard of the efforts to collect this data.
I think that's a great question. I'll tell you how it got to you in the first place. But yeah, I do share this data with the director of the public health division regularly, monthly. As I get it, I review and I give her key points. I also share it to anybody who wants to talk to me about it. I also have talked to QHawk too, and brought them the same PowerPoint, except for I did not talk to them about other creative ways to use it. And so we did have that higher level leadership with the CCOs and the behavioral health Medicaid director. I've had so many conversations with her about it. She also sees it. So whenever they send it to me, they copy her on it. And then we try to come up with like creative ways of like working internally to get this well known. I've also talked to our OMSPUD teams for 2 hours and talked through it so that they can be able to troubleshoot or even ask people who they're getting connected to for other reasons, if they're getting connected with vaccines, and really thinking it through that lens of the OMSPUD teams. I've also got to talk to all of the innovator agents so that they could also think about how I could present to the teams like you guys have, and either the CCOs at any level. I have no problem like talking to providers or community members. Just like with you, I never show the individual datas or the CCOs. I leave it blank, but I have the basic conversation on like, do you know these exist? What are you doing with them? Have you thought about pulling your own data and looking at this at different angles? And so I don't like to keep information to myself, but there is only me, and I do have lots of roles, but I do show up and talk even to the Oregon Housing and Consumer Supports and their homeless director and assistant director, and show it as much as I can and say, hey, this is what I have. Can you help me with your community action agencies? And I present regular over there, but I don't show them their data. I just help create ways for them to get vaccinated or connected to testing. But Gary, I'm willing to keep talking if people want to listen to me.
Yeah, so Rebecca came to the Innovator Agent group, I don't know, maybe a month ago now, and it was perfect timing because Donna and Camille had forwarded on the question from the board, and I was in the midst of gathering that information, and it was like kismet. It was perfect because as soon as Rebecca started presenting, and I realized there was this way to identify houseless people experiencing houselessness, and also all of the other potential applications. You know, she was looking at the COVID vaccine rates, and I found that really interesting. And if the CCO is interested in finding out how Rebecca has pulled their data and what it is, I'm sure she would set up time to talk with the CCO or to think about how the CCO could be looking at that data. And that's really why Rebecca came to our group, was how do I engage with the groups that you talked to about this. But there was so much potential for how to use these codes and identify people at risk that I thought it was something that, given that this group had an interest in what was happening with people who are experiencing houselessness right now, is very appropriate.
Excellent. So the by name list and the discussions that we are having locally, it seems to me that this would be an incredible tie-in to be able, you know, we know that the point in time count is an underrepresented number of the individuals in our community that meet the definition of being unhoused. And the by name list, if we can crosswalk that with the specific identifiers of individuals, it feels like we're starting to really wrap around the individual versus sort of these more general efforts, less strategic, a little more buckshot. And so does this tie into the by name in other communities, or is that maybe just aspirational at this point? Do you know?
I'm hoping I can talk to the other area of Pacific Source who does have the by name list and actually like talk to them and see if they're doing a very similar strategy that I want to do, where we can like share data with Oregon Housing Consumer Supports, or the community action agencies can share with their providers or the local public health authorities, and really like think about supporting the individual and getting them what they need to be healthy and to be able to play and work and thrive in our communities. And so that's my hope and dream, is that this happens. And so that's one of my strategies and dreams, that it will create that synergy that I have barriers of creating myself right now.
Excellent. Are we using the Z codes? Does anyone, are we using it in the region right now that we're aware of? I know, Donna, you mentioned it, but for Justin, unfortunately, had to drop off, but anyone want to comment about currently using it?
Well, I know Megan's not on the line, and I know that
Right.
they're using it at Mosaic.
Very good. Okay.
I also just want to jump in and share that I'd be happy to connect the Rebeccas with our team and see if we can help spread this great work around and see where the great connection points could be here.
Excellent, Tricia, thank you. And the Homeless Leadership Coalition, of course, being the organization that holds a continuum of care, there will be a transition in the future from Neighbor Impact to COIC. So if there's a way that we can engage there too, really helping to make sure that they have those foundational capabilities of being what we need them to be. So any other questions for the Rebeccas?
No, I just wanted to make one more comment. I just dropped it in the chat around Connect Oregon. There is an application. We're not there yet, right? We haven't perfected it, but we've invested a lot of resource in time into the solution. And I believe the state has done a really good job of supporting us in that space. So I just want to say, happy to pop in there anytime and help out as well.
Excellent. And really appreciative of the investment of time, but also your work to both Rebeccas, and for sharing with us today. for the board, does this pique your interest for more? Is this a space where we have the housing, let's see, what's the committee, the Stable Housing and Supports Committee. And Renee is our point person on that. We could have some of our providers come in. Is this a space that you'd like to have more input and understanding of what is currently happening in the region? Or do you feel like that's something that maybe we should have as a discussion with a small ad hoc group? What's the will of the board at this point? Iman, go right ahead. I see you're off.
Yeah, I don't know if it's a specific recommendation, just more musing that I think it would be interesting for us to share our collective data and to pool it together to draw some conclusions for areas of opportunity or mutual decision making. So I love hearing this, but it's kind of and I'm so grateful you asked the question. So what, then what? And so I do think that it would be cool. And I feel like I experienced so many barriers at St. Charles just trying to get collective data across our various providers. And so perhaps that could be an endeavor for the Health Council.
Excellent. Other comments? Linda, I saw your head nodding. Oh, go right ahead.
Not being a provider myself and just hearing this report, I'm unclear how many of the providers in the region are aware of the Z codes and how they're using it. It would seem to me the more robust data set we have, the better opportunity we have to have impact on it and to actually be measuring it. So one possible role for us might be educating providers if we knew whether that's a worthwhile effort.
Excellent point. So any other comments? Okay, so Donna, how about we take this offline, sort of tee it up, talk data, how do we find out who's doing what, and at least identify where do we sit today, and then that can help us identify where we want to be tomorrow. And that way we're not duplicating or assuming that others A, know about it, or B, are using it, and maybe neither of those things are accurate. So excellent. Well, Rebecca and Rebecca, thank you so much for your investment of time with us today. Really appreciate it.
Thank you.
Of course. And I'd like to welcome Peter. And then also Miguel, but first we'll go to Peter. Wonderful to see you. And thank you for joining us today. And we are going to talk value-based payments. So I will turn the floor over to you.
Great. First off, can everybody hear me okay? Great. Lots of familiar faces and names in the room, but some that I am not aware of. So my name is Peter McGarry. I'm the Vice President of Provider Network for Pacific Source. Tricia asked me, hey, come and present and talk about value-based payments. And so I put together a slide deck that I'll present, and hopefully that hits the mark. Value-based payments are a huge topic, and you can go deep in many different areas. So I've got a presentation that I think would be interesting, has some information about the requirements, how are we meeting some of those requirements, and then what's been sort of, I pulled some really old information about just Central Oregon for Medicaid and thought I'd present those, and then maybe we'll stop, ask questions, and if you want to bring me back for a specific area I didn't cover, I'm totally happy to do that. I've been doing value-based payment contracting in Central Oregon since 2010, so a long time, makes me feel really old. So I've got a nice perspective about sort of where the communities come from and what we've been able to do. So without further ado, I'm gonna share my screen. And let me ask, are people able to see this?
Yes.
Great, I'm gonna get rid of the audience here and just proceed. So I'm gonna talk about three sort of key areas. One is, well, two of the areas are sort of CCO must-dos. What are some of the requirements that happened in 2020 that formed and really moved the needle in terms of value-based payments? So two of those areas are, the first is sort of you have to expand value-based payments in certain areas. The state put forth 5 areas and said, do something new in these areas. That's our expectation of you, CCO or Pacific Source. And then secondly, they have some expectations over a 5-year trajectory of saying you have to increase the number of dollars that are being paid within value-based payment arrangements. And so I'll share some information about that. And then I just put Central Oregon achievement. I went back to some of our sort of financial reports dating back many years just to sort of tell the tale of sort of what we have in Central Oregon. And quite frankly, what we have in Central Oregon is a model where providers are part of the same success structure, part of the same model in a way that's pretty unique and deeper than many of the other CCOs where PacificSource operates, and also some really good financial results over time. Not every year, but most years, and I'll share some of that information as well. But first, we'll talk about this first one. Hey, the expanded use of value-based payments in particular domains. This grid sort of tells the story of where OHA sort of evolved to. It didn't start out this way, but eventually through COVID, they said, hey, by 2022, there needs to be new value-based arrangements in maternity, behavioral health, and the hospital arena. So come up with something new. It can't pre-exist. It has to be something new. So that's our expectation of any CCO, and that's what essentially PacificSource we want you to do in Central Oregon. Down the road, and by 2023, there's an expectation to do something in the children's care arena, and in 2024 in the oral health arena. Again, new value-based arrangements. But for now, what we've done is something in the hospital, behavioral health, and maternity space. If you have questions along the way, feel free to interrupt, because I'm happy to stop if I've sped past something that isn't very clear. What we've done in Central Oregon is this. We've sort of come up with the 3 by the beginning of 22. And what we've submitted to this, we've done a variety of things, but what we submitted to the state was, hey, for maternity, we have some new metrics that pertain to getting postpartum care within 8 weeks. Those metrics didn't exist prior to 2020, but they exist in our community contract now. And so we cited that as something we've done in the maternity space to have providers focus on maternity care. And we also put value-based payments arrangements with SageView. The beauty of SageView is you get a double bonus. You get a behavioral health credit and a hospital credit. So by doing value-based with SageView, which previously was not a value-based arrangement, we check the box on that as well. We have some other plans for what we're going to do in the children's care arena and oral health care, some of those in development, and we'll get to those in the near term here. The next thing, and sort of what CCOs must do, is you have to increase the number and the percentage of dollars that are in various levels of value-based payment. This is where it gets a little complicated, because the framework that the state has come up with, and in fact CMS and many states have come up with, is this. A fairly confusing framework that says, hey, there's 4 categories of payment that go from fee-for-service to capitation, and the state has expectations of PacificSource in Central Oregon to have payment arrangements in some of these. Instead of having this sort of confusing grid, I created a much simpler to understand grid, which looks like this. Category 1 is just straight fee-for-service. You pay for a unit of service, whether it's an office visit or it's a surgery. Category 2 is, hey, you're not just paying fee-for-service, but you've got some bonus. You can pay for quality, you can pay for some sort of an incentive, but you're doing something beyond just paying every time a service is provided. You're actually making incentive-based payments as well. Category 3 is, hey, fee-for-service with a bonus payment or an incentive opportunity, but there's downside risk too. If a provider doesn't achieve metrics or performance, they actually have some financial consequence for that. And category 4 is full risk or capitation. It's a provider that's saying, hey, I'll take a prepayment for the services that I will do. I'm at risk for that because if there's a lot of utilization or very little utilization, I'll get paid the same either way. And having some tie to quality is important there. And when the state says, hey, we have expectations of the provider community and the CCO, they're largely in these circled spaces in green, 2C and 3B, meaning at some portion of time, they want to see some incentives for providers, and they want to see eventually up and downside risk tied to quality. That's what 3B is. And quality is really important here. If there is no quality incentive in those arrangements, it falls into this 3N or 4N category, and it doesn't count. So you can do as many fancy financial things as you want. If it's not tied to quality, the state says you don't get any credit for it. that's maybe my review of the framework. Let me just see if there's any questions about that, because I don't want to speed too fast here if in fact I've talked about something that's not clearly understood.
I'm not seeing any hands up quite yet.
Okay, so yeah, silence means I was perfect, so I will move on. So this is what we've done in Central Oregon thus far. I'll get rid of everyone here. So the requirement for CCOs all across the state is this: by 2020 and 21 and 22, you start having to have, hey, at least 20% of your payments value-based at 2C, moving up to 35, moving up to 50, moving up to 60 and 70 by the end of 2024. They also start having some expectations that you have up and downside risk tied to quality, which is 3B. And by 2023 and into 2024, they want to start seeing some dollars in those spaces as well. When PacificSource put forth its request for application and said, this is what we can do, we said we can beat those targets significantly. We think we can be at 60% right out of the gate, moving up into the 80s over time. Why could we do this? Well, we already had value-based payments in Central Oregon, so this was not inconsistent with what we had been doing for years leading up to 2020. And so we said we can do even better. And in fact, the first year we have evidence of what our percentage is 2020. We should have 21 numbers soon, but we're still running them. But we achieved 62% in the first year of CCO 2.0. Again, pretty close to our target, not quite there. I'm hopeful that we will actually see an increase in 21. We have done some new value-based payment arrangements, but we'll see what it yields for us. Does that make sense to everybody? Often the questions come up like, what are those contracts? When you do a contract that's 2C or it's 3B, what does that actually look like? So I've got a few descriptions of our contracts and the kinds of things that we have in Central Oregon. I thought that would be worth going over at least a little bit as well. This is probably the simplest and best example of category 1, fee for service only. What does it mean when you're in category 1? Well, you're paying for a unit of service based on some conversion factor, so that dollar amount, and I just picked $37 as an example, that amount gets multiplied by whatever the value or the extensiveness of the service that's provided, and a payment is made. There's no risk withhold, meaning the provider doesn't have any downside risk. There's no healthcare budgets that are created. There's no surplus or deficits. There's no quality incentive. This is bread and butter contracting. And we do have some of these contracts, certainly in the ancillary spaces and in many places, we have this arrangement. We haven't put in value-based yet, but that's certainly not our goal. Our goal is to do things further down the land framework. This is category 2. So you could take that same conversion factor and you could have some things. You might not need to have risk withhold or downside risk or even a healthcare budget, but you can still have quality metrics. You can say to a provider, look, we'll pay you fee for service, but if you do really good on quality metrics, and we'll measure those quality metrics. I picked 3 of the sort of QIMs that are pretty classical: A1C control, blood pressure control, and maybe immunization rates for adolescents. If you do good, provider, in those areas, we'll pay you some bonuses. We won't pay you a bonus if you underperform, but if you have good or even superior performance, we'll put some dollars to those. And this is a classic category 2 arrangement that we might have in place. This is category 3. So what's distinctive about category 3? It's right here in this box. You have your $37 conversion factor, but the provider has a piece of that payment held by PacificSource for budget performance. So yes, there's a healthcare budget. When you have a healthcare budget, one of 2 things can happen. You will either have a budget surplus or a budget deficit, and you can have some quality metrics as well. This is what we have in Central Oregon with many of the, almost all of the members that are assigned to physical health providers. Money gets paid from the state of Oregon to PacificSource. There's a variety of deductions that take place, but for that population of members, there's a healthcare budget that represents the revenue for physical health and behavioral health services. What happens throughout the year is claims come in, payment arrangements come in, and lots of expenses get accrued against that budget to create one of 2 eventualities: a deficit or a surplus. If there's a deficit, providers have some obligation to pay for that deficit to a certain limitation. If there's a surplus, some of those dollars can get redistributed to the providers as well as to the global budget. And those amounts can be influenced by things like performance around quality. So potentially a deficit could get bigger if quality is not what we want it to be. But on the other side of the equation, a surplus could get bigger if quality is good. So this is an example of category 3, a budget-based model where there's up and downside risk tied to quality. The further evolution of this model is one where there isn't a healthcare budget at all. There's capitated payment. So there's no conversion factor, there's no risk withhold, there's no budget actually. What there is a capitation payment. Premium comes in from the state, and for whatever service the provider is willing to take capitated or full risk, that payment is made to them. And they are responsible for the utilization and the care for a patient population for that fixed dollar amount. Even under capitation, you can have incentives tied to quality because you can say, hey, there's a slight reduction in that capitation payment. We will hold it in a pool. And when quality is good or bad, that determines whether that quality withhold is either paid or not paid back to the provider. So this is the dimension of land category 4 that has capitation tied to quality. Let me stop again and just see if there's any questions based on that. Silence means no. So what do we actually have in Central Oregon? So I've got 2 more slides that sort of speak to the model that we have that's unique in Central Oregon, and then some of the multi-year results. So first to the model, I just tried to draw something that was simple and tried to depict what we've had in Central Oregon for years. And what we have in Central Oregon is basically premium comes in from the state of Oregon, and minus some deductions leads to a physical and behavioral health community healthcare budget. What does community mean? That means all the members that are assigned to primary care physicians within COIPA and Mosaic and St. Charles Medical Group are all pooled together into one fairly massive budget with tens of thousands of lives in it. And all of the revenue for physical and behavioral health goes to form that multi-million-dollar budget. If that budget performs well, you can have a surplus, and if but all the money is spent relative to that budget, that would be a deficit. So a couple of things happen here. There's been typically a lot of success in this budget performance. So typically there is a surplus, and when a surplus happens, what takes place? Money per the contractual allocations gets split between primary care providers, specialty providers, St. Charles Healthcare System as the predominant community hospital, the local county CMHPs, Deschutes, Jefferson, and Crook, and even the Central Oregon Health Council typically through the global budget gets some of the surplus dollars that are derived from this model. There's a second pathway of funds that also flows to the community providers, and that's the hospital capitation. St. Charles Medical Group is paid via that category 4 thing we were talking about earlier. They are capitated for the hospital care for the entire Central Oregon CCO population. But a piece of that capitation is held based on some hospital-based quality performance that all providers can contribute to. And if those performance metrics are achieved, then that amount, that hospital capitation withhold, can also go to be distributed amongst primary care specialty providers, St. Charles Health System, and the CMHPs. And to the extent some dollars are not earned because quality metrics are not achieved, some of those dollars could flow back to the global budget as well. So this is the model we have right now. We've had in some cases, 2 of these budgets running concurrently. This is 2021 was the first year we had them combined into one fairly massive budget. And I'll show you some performance about that in a little bit. What has this done? What has this community budget done? Well, again, it's distributed surplus to providers as well as the global budget and the Health Council. QIM performance, if good, can mean more money flows into this mechanism. So if quality incentive metrics as viewed by the state towards the CCO are positive, that can increase the amount of money that goes into the healthcare budget, which increases the potential for a surplus being distributed to everybody. The unique hospital capitation means really if one party in the community, primary care or specialty or hospital providers succeed, everybody shares in that success. So the uniqueness of this model is a different provider in the community, their success is your success, and your success is success shared by a variety of other people in the community. So amongst the providers, everybody's got the incentive to see that other providers are successful. And then lastly, and I think probably one of the most unique things, is the model has been a place where we can say, you know, there's a dire community need for something. And maybe as an expense to this model, we can pay for something that's good for our community and good for members. Examples of that are a pediatric hospitalist program that's been in place many years, and the dollars from this healthcare budget go to fund and stand up that program, which probably isn't self-supported through its own sort of fee-for-service reimbursement. And most recently, there's Deschutes Stability Center that was something that was funded through the budget negotiation. Again, that's something that was deemed a pretty significant community need, and there was a need for funding for that, and folks got together and through this budget mechanism said, let's create some funding for something like that. This is a confusing topic because it's about our most advanced value-based payment model that we have across all CCOs. I just wonder if there might be any questions about it.
I have a quick question. Where is dental in this, or oral health in this scope?
Great question. So it's not in this. So we do get premium from the state that includes a variety of things: physical health, behavioral health, dental care, NEMT, non-emergent medical transportation. But this budget only encompasses the physical and the behavioral health. The dental piece is not part of it, but we have arrangement with DCOs, or dental care organizations. We pay them, actually category 4 capitation. We give them those dollars. We say, you DCOs are at full risk. You have some quality incentives as well, but those dollars go off into a different model that is not shown here.
Got it. I have another really naive question.
Yeah.
So is this, when we set the basis for the value-based payment, is it based on the actual cost to provide the service to begin with? Or how do you determine, you know, if we were to just take behavioral health in terms of the cost to provide, how does that get reconciled in terms of the need, the cost, and then setting a metric of how you're going to sort of manage the success of that?
And you're talking about behavioral health specifically?
Sure, just as an example.
Okay, well, I think that's a great question. I could go a number of places. Maybe one of the places I'll go is each provider organization says, hey, I'm providing care for Medicaid members in this community. I need to, as much as possible, cover my costs, right? So what I need for the units of service I'm projecting, I need a certain dollar amount. And hopefully through this negotiation process, we can get as close as possible to covering needs. Beyond that, like every provider organization, they have their own sort of operating margin. They're either for profit or not. Hey, they may need some additional dollars for contingencies. A good example is the CMHPs. Sometimes they're like, yeah, I have unpredictable care expenses for this community. I don't know what the acuity is going to be. I may need to cover my costs, and I might have to have some residual dollars to cover some extra care that's provided in the community. Or I may be doing some things that doesn't have a billable. I can't actually bill you for it, Pacific Source, but it's a vital community effort and a vital community service. So it can get pretty much in the weeds, but usually there's a negotiation around interim reimbursement, and you surround that with aspects of quality and cost control and a community model, and you sort of build to something that fits within this model. But I do want to say many providers, if you talk about ancillary providers, labs, surgery centers, for example, a lot of them are still in this, hey, I'm just covering the cost every time I provide a service. But it's those providers that are involved in sort of the sort of total care for their patients, or maybe their world blends in the dental and the physical space, or the behavioral and the physical space. A little more of a complex conversation about how to pay for them and help keep them going. I don't know if that answered your question, but
it certainly did. And I just really appreciate how well you distill it down so that it makes sense. So thank you.
Cool, thank you. Other questions before I go to my last slide? Okay, so I went back, we have these reports that go all the way back to like 2013. And so I went back to each and every one of them for Central Oregon, and I said, how is the budget performed each and every year over the last several years. And that's what this slide is. There have been three main entities that have had healthcare budgets over time. It's usually the COIPA budget and the St. Charles Medical Group budget. And it's usually a 3-to-1 ratio in terms of the size of these budgets. 30, 40, 50,000 lives in COIPA, St. Charles 10, 12, 15,000 lives in that budget model. And so how have those budget models done over the years, and what kind of surplus or deficit has been created from those models? And so I went back to 2013. I actually found COIPA's, but I couldn't find St. Charles's. And you can see, like, in that year when we just had a physical health budget, we didn't have physical and behavioral health together in a single budget. But when we just had physical health, there's a $4 million surplus out of the COIPA budget. And again, I'm not sure what it was for St. Charles. And at that point, Praxis eventually spun off and created its own budget. But at that point, Praxis was part of COIPA. And the amazing thing when you look at this is, you move forward in time and you see how big was the surplus, like how good were the providers regarding sort of managing the cost of care for their patient population. And it's pretty compelling going from 2013 to 2019. This budget model that we have created has led to, providers actually being like, yeah, I want more Medicaid members, right? Which is exactly what you want. You want to open up access. You want to make sure providers are looking at a Medicaid model, like that's an advantageous model. Well, the dollars that we've been able to funnel back, distribute to community governance, invest in things around community health has been pretty outstanding from 2013 to 2019. The first year where we did not see such good results was 2020. That was the first year of CCO 2.0 and the integration of physical and behavioral health together. COIPA actually had a deficit. St. Charles had a surplus. And that was the first time we had seen a deficit in a long time. But what is really interesting is the first year of the combined COIPA St. Charles mega budget with 50,000 lives in it. We're seeing a really big surplus for 2021. And even Praxis, who left COIPA and sort of created their own pretty small budget, they're showing us a nice surplus too. So a 2013 through 2021 trajectory has shown this model, and how all providers are working together has really yielded some spectacular financial results, and probably doing just what the OHA would expect out of a CCO. I tried to get into some quality, like, hey, has our quality dimensions increased over time too? I just couldn't pull that together, and there's probably other experts at Pacific Source could better speak to community quality than myself. But I just thought this was interesting. I hadn't seen this before, and when I look back on it, you could add up all these numbers and say, wow, that's a lot of surplus that was derived over several years, and it's kind of good to see, and it's through a lot of hard work from a lot of the provider community. So I don't want this to be like CCO success. This is the community success, and a lot of people are working really hard on it. Donna, I see your hand is up.
Thank you. It's good to see you, Peter, and your presentation was amazing. Just as a matter of clarity, on this particular slide, SCMG is St. Charles Medical Group, is it not? It's not the health system.
No, yeah, you're right. It's the medical group. So we assign budgets. When we say, aha, provider, you have a budget, it's usually based on primary care, right? Because the members are assigned to primary care, and those primary care providers are responsible for all the care the member gets: hospital care, specialty care, pharmacy care, all of those things. So what that means is primary care entities have a budget that can be negotiated and agreed upon, but a hospital does not. The members aren't assigned to a hospital. So the hospital becomes an entity that, yeah, has their own reimbursement mechanism, but the hospital doesn't have a budget. Primary care entities have the budget.
And I know it's semantics, but the St. Charles Medical Group is part of the St. Charles Health System.
It is. I mean, but it's two different divisions. We actually have two different contracts. We have their medical group.
Correct. You have the hospital base and the primary care. Yeah.
And the other thing is, we have members from some other CCOs on the other side of the mountains that sometimes come to St. Charles. So we have to have a mechanism to account for that, and St. Charles should get paid for those services. And so we have a hospital agreement and a separate medical group agreement, and provide services as they go. Other questions? I'll stop sharing and just see if there's anything else folks wanted to cover.
Brad, go right ahead.
Thanks. Hey, Peter, I appreciated your presentation, but honestly, it raised a bazillion questions for me.
It tends to, yes, do that.
But we don't have time here for all those questions. It also answered some questions, so I appreciate that.
Good.
I was hoping, I'm just curious, is there any evidence that this is leading to better health outcomes? So we're looking at money. I see money, and I see us measuring money, but that I have a bunch of questions about that. But are we actually achieving better health as a result of all of this value-based payments?
Yeah, I'm not sure I have a singular clear answer on that. You know, you can measure it. You can say, yeah, there's been a nice dollar distributions by virtue of surplus. That doesn't necessarily mean better health, right? Yes, some of those dollars could be invested in community health, and you would like to think, yeah, that translates to better health for the community, but can you prove it through like outcomes data, things like that? Certainly much harder. I think one thing you could do is look at quality as a dimension. Like I say again, like bring somebody and say, have the quality dial been moved over time? That might be a good way to speak to, hey, have we done a good job here? Yes, quality is not outcomes data. Outcomes data is sort of like, hey, what's a good way to measure health? Are people waiting a lot to get care? Are they having detrimental things happen because they're waiting? Or, hey, are we heading off disease well on the front end by virtue of this model? I hesitate to answer in the affirmative. This model is making dollars available to do those things, but how you invest those dollars, how providers invest them, how the Health Council invests them, it is truly, I think, the vehicle by which you would say, hey, outcomes have improved. But I can't 100% attest to that right here in this meeting.
Thanks. And then there's just one other question I had. If nobody else, I don't see anybody else raising their hand. And you answered part of this with your, I think you gave an example of like a lab, and you wouldn't have value-based payments with a lab. This is just very transactional. I think that's what I understood.
Yeah.
Is there where are the resistances to increasing, to achieving those goals of increasing value-based payments in the system?
Yeah. That's a great question. Often we go to a community that's maybe better answered like when we were a new CCO in 2020 in some other communities, not Central Oregon. And so all of a sudden we announce ourselves, hey, we're the CCO, let's do value-based contracting. And you hear some providers say, whoa, I'm not used to that. Like the former CCO didn't make me do that. I don't know that I want to take downside risk. That feels scary. Or maybe can we dip our toe in it? Like maybe do category 2 and like we can trust you a little bit, Pacific Source, you can run these models and then maybe we'll move to category 3. We hear some of that. Sometimes we hear, hey, in this COVID environment, workforce issues. I'm struggling to get people in here to do some of the aspirational things that the community needs. Like I've had 5 people quit the other day and I'm running on a shoestring right now. I can't take on an ambitious value-based payment. I need to keep my financial model simple and understood, and I'll move into these other incentive-based arenas once I have some stability in my workforce and things have stabilized a little bit in my community, but that feels really risky to me right now. So some providers are just risk averse. Some providers are like, hey, dealing with a difficult environment right now, and that's a hard place for them to say, yeah, I'll take a chance on that value-based arrangement.
Does this maybe also open the door, though, for thinking differently about how we're providing care, given the fact that we probably will have, I mean, some of the projections I'm reading, it could be a decade or even longer of the workforce shortage. I mean, we are really sort of embarking on a different type of workforce in general and service delivery. So I just wonder if you have a perspective on that when we're given the choice of how aggressive do we push, or where do we sort of lean in on it?
Well, Pacific Source has been given targets, goals, expectations by the state. So we have to sort of go to providers and be able to speak to why this is a good thing, why there's opportunity you're foregoing. It's one thing to say, the state wants us to do this thing, so get on board. It's another to say, hey, you're sort of missing out on some opportunities. If you think you can do good in these dimensions, there's incentives for you that you might come to count on rather than thinking of it as risk. You might you might actually be like, wow, I'm glad I have that value-based arrangement with Pacific Source because that helped pay for that extra therapist, or hey, that new software platform, or whatever. So, you know, value-based payments, when you first say those words, sometimes a provider thinks of it as, oh, that's a bad thing, risk. And some of them say, hey, that's an opportunity. If I can manage that risk well, this is a really good thing. And it's sort of how do you have a dialogue with them that's not in this space, but it's sort of in this space. Because I can tell you, like, the providers that are in this model, and Quaipa and St. Charles, when we pay our settlement amounts, it's a big amount. And I think they count on those to like that one year I showed, the 2020 year that wasn't very good. That caused this like, oh my God moment, because a lot of those organizations, they sort of counted on a big surplus payout. It didn't happen. And it really sort of galvanized those groups to say, what are we doing wrong here? What can we do to get back to that space? So I think it becomes it can become a vital part of the economics of a lot of these delivery systems. And hopefully they view it that way, that like by paying attention to these and making sure that like, you know, where your incentives are and where you should put your resources and work, you can actually do better for yourself than take on a bunch of risks that you can't manage.
Okay, other questions or comments? We don't always have the pleasure of having Peter with us, who's behind the scenes doing all this great work. Anyone else have anything that they'd like to add or questions you might have? Okay. Well, Peter, as always, wonderful to see you and great job sharing that. Oh, Justin, please. Yep, dive in. Oh, you're saying goodbye. Okay, got it. Okay.
That was a goodbye wave.
Wait. Okay.
Let me just leave with this. I'm happy to come back and describe the model, even as it evolves further over time. It's a confusing topic, and if you don't live in it every day, people can throw out terms, and you can be like, I don't understand that. So feel free to bring me back at any point. The more repetition, the more talking about this, the more it becomes familiar, and then you're not surprised or confused when somebody starts talking about it, and you sort of lose how it all fits. I'm happy to come back and have further conversation.
Really appreciate that open door. And Brad, I would encourage you, let's draft a list of questions. You said that you had a number of them, and if anyone else has questions, maybe we could tee that up for the next presentation, or at least get some communication going between kind of the board and Peter, and because knowledge is key.
Yeah, Brad, fire them off. Use Trisha as a vehicle to get them to me. I'm happy to give you a reply that hopefully scratches the itch.
And Brad, if you're thinking you understand this the first time you hear it, you're wrong. Just saying.
Rick's been my long friend in the value-based payment negotiations, so he speaks from some
yes, and I still get it wrong routinely, and Peter has to correct me routinely. So it's a steep learning curve.
Rick's got an iota of credibility on this topic. So yes, he's right. Yeah.
I don't pretend to understand. Trust me, Rick. But I'm trying. And Tammy, I just want to ask, maybe you're already going to handle this, but if we could add 5 or however many minutes it is to the agenda to give Miguel his full time. I'd like to propose that.
Oh, absolutely. You bet. Yep, we'll be just fine. And so also thank you for the extra time from Peter, and as well a bit of grace from Miguelis. So Peter, thank you. And
thank you.
More to come. Really appreciate it. And I will go ahead and if we don't have any other questions, I'll go ahead and turn it over. The floor is yours, Miguel. Wonderful to see you.
Thank you so much. So thinking on time, I did a trick this time. So you have in your package the entire presentation, but I'm gonna share with you only some slides of that. So thinking that we may not have enough time. So let's jump immediately. By the way, for those who don't know me yet, my name is Miguel Ángel Herrada. I serve as the Health Equity and Diversity Strategist for Pacific Source. And it's a pleasure to be here with you to share what we have learned, what we are doing in our health equity plan. Next slide, please. So just as a reminder to set the panorama about what we are talking about, the health equity plan is a 5-year plan that we have to advance health equity as a system in all our CCOs. is based on the cultural and linguistically appropriate service standards, the CLAS standards, and is designed as with a 5-year framework in mind. So that means that we all our projects are going 5 years. Not all of them have the same life, and we are reviewing that continuously. And so according to these updates, we change our goals. Just to give you an example, the report progress that we are working now is due in June, but we have not yet received the feedback from OHA about the guidance that we need from 2021. So some of the things may change according to what OHA is going to send us. So next slide, please. Yes, so to give you an idea of the focus areas, we have 7 focus areas working on 2022, but these focus areas have around 52, 58, I don't remember the number, projects going on together with several teams involved on doing that in all the regions. So we continue working on the cultural and linguistically appropriate grievance and appeal processes. That was a very strong claim that we listened 2 years ago when we prepared the first part of the plan. And we have made some advances that I'm going to share with you in the next slides. So we are working on RealD collection and analysis. This is a super important part with a new component, component of this, which is SOGI, that stands for sexual orientation and gender identity. So you all know and understand how important it is that we collect and analyze this data to properly give the service to our members in the way that they need it. Cultural and CLAS as an operational framework for Pacific Source, it continues to be one of our focus as workforce diversity, language access, and member communications, all of them so important. And we will have more time to chat about this later. We have the last one is a new focus area around advancing, creating infrastructure to advance health equity, and also creating true partnerships. That's the way the OHA is calling that. It's a new component that we are just developing right now. Next slide, please. And please stop me whenever if you have any question. So what has been our successes in 2021? So grievance and appeals, that was a big claim from our community members and also the members in general, community partners and members. So we were able to create and train traditional health workers specifically to serve as champions in connecting our members with our process, because many people has fear. They share with us that they don't know how to do it, either because it's complicated or they are afraid to make a grievance or an appeal. Sometimes it's because we have small communities where everybody knows each other. Sometimes it's just because the process is so foreign for some of them that they just don't know how to approach that. So the traditional health workers are trained now to help us to understand what is happening, and that was a fantastic way to begin. We plan to expand this obviously with other providers, and also basically a non-retaliation statement was created that was so needed for these populations. Next slide, please. In the workforce diversity area, so we deployed resources to each CCO region to support the growth of diversity in the workforce pipeline. This is a complicated thing because, as somebody said, I think it was Tammy, this is a thing that it cannot be solved easily, because when communities ask for workforce diversity, they are not just asking for interpreters, right? Or traditional health workers. They want the providers to look like them. And this is beyond the capacity of a project like this. But we were very successful to support programs like the programs here locally, that the programs at the COCC is doing to create more traditional health workers, and also programs of medical interpretations, and obviously the grants, the community health excellence grants that Pacific Source is providing. So a lot of great success for us in 2021. On training and education, also, it was a success for us that almost, I don't remember the number, but it's around 90 something % of Pacific Source employees that have received foundational training about the basic, to understand what is implicit bias, what is cultural responsiveness, and we expand these opportunities of these learnings to providers. Some of them have been able to access. We need more participation of providers. We have tried several formulas, and that there is a lot of work to do in that area. And we totally understand in this time providers, maybe this type of trainings are at the, it's more work for them. So we understand that. But internally at Pacific Source, we have a great success together with other strategies that the company launched, not only on Medicaid area, but for the entire company, creating a new value that is focused on health equity, diversity, inclusion, and social justice. So we have many other projects there, and together have created a good ambience at Pacific Source to continue to advance the agenda of health equity. So we are very happy with that. Next slide, please. So about language access. Oh, yes, about language access. So for us, it's important to know what is really happening when our members have an experience where language access could be a barrier. And so for the first time, we launched an assessment, and we know what happened during these exchanges where our members needed interpretation, for example. And there is a lot of work that we need to do still to improve that. This is a project that will continue in 2022. But for the first time, we have this data that our team collected about what was the quality of interpretation, and we discovered many, many things. So we're very happy with that. Member communication. In the area of member communication, we continue to develop our resources, and we were able to create some multimedia resources for our members, and including American Sign Language, that is a new area that in the past we really didn't have too many resources for our members that needed. And so this is also a good advance for us. Next slide, please. Oh, yes. So let me tell you about our new projects. That's very exciting for us. Next slide, please. So in the new projects areas, we have in the class standards. So we want to create some process internal to standardize the quality of the materials that our members receive. And this is a complex thing because many times what the members receive, they have templates and with either medical or legal terminology that makes really complex to understand, for them to understand what is there, or what to do with that. So we are exploring some ways to do better work when we communicate with our members in written language. So at least to create a complement that explains that, well, you have an action to do with this, or why you are receiving these letters. So we don't change the highly regulated format, but we add information to make more clear the communications that they are receiving. And the same happens for in the language access area. So we plan to enhance our survey and understand better what is needed, how is the quality of the interpretation services that they are receiving, our members in real life. And we are discovering many things where things can be improved. Next slide, please. So in these member communications, as I said before, so try to expand the way that we communicate with members, including helping them understand what is there in the communications in a way that is easier for them. And then we have the new, totally new focus area that we don't have still the language that we need to, or the training to develop this area, but we are already encountering our CACs and our other organizations to try to understand what do you think is needed for this new focus area that is really about advancing health equity and creating community partnerships. Could you give me the next slide? I want to share with you the full text. Thank you. The full text of what is this new focus area around organizational health equity infrastructure and community partnership. And so what we understand on this new focus area is that OHA is asking us to create a different type of relationship with the community, where it is not only contractual or business oriented relationships, but they really want true community partnerships. And we don't know what is a true community partnerships. We need to ask the communities what a true community partnership is for you. So we have approached the equity collaboratives in our regions, and we have met with them and also sent to the CACs a written survey. And the answers that we have are very interesting because it is really talking about, they tell us what we need is an ability to create a relation that is based in trust. So it is not just a service exchange, but to create trust. So the first thing we can take from what we have learned is that they are telling us, don't go alone, wait for us. Let's do this in collaboration. Let's advance this new focus area together. And as you can imagine, doing that requires much more time because a collaborative process requires that we really build that level of trust with the communities we work with. Not everybody is included. So we need to make a better effort to include those areas or those communities that are not yet part of our structure, to have a better, more representation and to work this together. So this is super exciting. It's a big challenge, but that's what I can share with you about this new focus area. And I stop there. I think I am in time. So please, next slide, questions. And yeah, let's talk about that.
Well, that was great. My first question is, what surprised you the most in doing this work? Is there something that you just really didn't anticipate in terms of a need, or maybe I'm not even asking it the right way, but what maybe just your observations is kind of what I'm getting to.
Thank you, Tani. This is a great question. So it is not a surprise, but what I confirm is that there is a lot of work and a lot of effort that needs to be done just to create the collaboration. And this is valid also for the problem around workforce diversity. So what we are seeing is that the communities need to be organized. We need to support more the leadership comes from diverse communities. And that requires effort. So it is like you need to work and put money before beginning to work or before beginning to planning. So you need to because remember, many of these communities, they lack of the social support for that. We are living, my community is living to fight survival issues, right? So how to get a good job, so when you want to bring these communities in a role position, where there is leadership, there is very little opportunity. So now Pacific Source or the CCOs cannot do that alone because it's beyond our scope, frankly. So we can support, but that needs to come from the communities itself. So there is a lot of opportunities for the Health Council to support the role of community partners to create those leaderships. And it's just to put in the mind of the communities the possibility that, yes, I can be a doctor, yes, I can be a nurse, yes, I can be part of my community. And that is not it's not going to happen just because we need to put resources there, we need to put projects and work with the communities. That's what I have learned.
I love it. And all with the really foundational pieces of trust that I heard you say too. So awesome. Thank you. Any other questions or comments? Brad, please.
Just a quick, thanks, Miguel. Gracias. Quick comments. I was just reminded of the last thing that Miguel just said there around workforce diversity and essentially putting it in the minds, raising the awareness of our youth. And not just our youth, young adults, youth, whatever, the opportunities in the health field and thinking of that broadly, social service as well. But Kat at Volunteers in Medicine, I don't know if you're still doing this, Kat, but you were having students go in and walk through your clinic and talking to them about it. And that was a cool project. And the other one that I was thinking of is there was one with, I think it's scribes. So having people be scribes, like essentially working with doctors and nurses and being the scribe, taking notes and thereby learning and being actually, hands-on learning by being a scribe in the medical field.
And I think St. Charles was doing that a few years ago. I don't know if that program continues, but they have also a great program inviting students. Yeah.
Yeah, this is Kat. Thanks, Brad, for that shout out. That program we do in connection with St. Charles, and it really is a great day to bring high school students in, particularly who might be interested in health careers from rural areas, and really give them some hands-on opportunity to, not only, manipulate things and do similar type work they might be doing, but also to connect with older mentors in the field who can answer questions and, give them motivation. So we have not done it for the last couple of years because of COVID, but we really love the program and would love to keep doing that.
Thank you, Kat. Thank you, Brad, for your questions. If you have any other questions, please contact me either through Tricia or Kristen. And thank you again for the opportunity to be here and present once more about this.
Always wonderful to see you, and thank you for your great work.
Thank you, Tammy.
Yes. Okay. So looks like the next, Donna, I was trying to track what you were just mentioning. So, so we had an executive session set for today. And as the board might have already observed, we are light on board members today. And so the discussion of the hiring of a new executive director, we wanted to make sure that we're making that decision collectively as a larger body of board members versus a smaller group. And so Donna and Camille, thank you for sending out the request for additional time next week. It sounds like we do have a date and a time, but it's still not ideal. It's a great group of very busy people. And so it sounds like the date and time right now is that 7:30 or 7 on the 15th, Donna?
It's at 7 right now.
Okay.
So it may change to 7:30, but that would just shorten your time to 30 minutes because I don't think anybody can go past. But we're still working on having the most folks in the room as possible or on Zoom. No, it's on Zoom.
Is
Okay.
that AM?
That's correct.
Can we come in our PJs?
Oh, Justin, of
Yes.
course.
Definitely PJs, and I'll turn it over to the recruitment chair. So I hope I didn't overstep. I was trying to tee us up so that.
No, please, you
okay.
you should take it. The 7 a.m. I think the 7 versus 7:30 issues. I have a pre-arranged meeting I have to be at. I can be there at 7:30, but you guys don't need me. I mean, you guys like, you know what to do. If you want to just run it at 7, you know my vote. It's been the same 4 times. Like, just please feel free to start at 7. Let everybody have their time to hear from everybody and negotiate it out or whatever, and I'll join at 7:30 and cast the same vote I did 4 other times. So like, we should be good.
Okay, well, there's something to be said for consistency because I continue to call Kirsten. So I mainly wanted to make sure that you had an opportunity to continue to lead the committee that you we were asked to.
Everybody's a
have you do. So,
professional.
okay.
Everyone's a professional. It's no big deal.
Okay.
Like, just move it forward so it gets done. I don't care.
Okay, groovy. So 7 a.m. on the 15th, PJ's welcome. And it sounds like a Zoom link will go out. So that is for the board members. And if you are on the committee and you will not be able to participate or maybe community member or whatnot. So just would love to have whatever comments we might want to have included in that discussion. But if you're in particular on the committee and not able to be there on that day and time, please let us know. We know where you stand, Justin, but if anyone else is not going to be able to be available, please let us know. And I'm going to check because I'm getting some chats here. Okay, so Tuesday, 7 a.m., link will go out. And I think that concludes our business for today then, if I'm not mistaken. All right, so we have the gift of extra time. Is there anything?
I think Dan put something in the chat. I haven't been able to read through it. So Tammy, did you see that?
It was the longest thing in the chat all day, and I apologize.
Good grief, Dan.
I do
It's
see
like
it,
a
yes.
paragraph.
For $20, we'll let you actually just say it in the meeting.
Okay, sounds good. I'll pay you
Okay.
later. No, I'll pay Miguel. No, I mean, I was trying to draw a parallel to these complex challenges, and I'm just so intrigued, and through conversations with Brad and Miguel and others over the years, this challenge of, I remember talking to Brad one day, and Brad, you said, one of the things that's really a challenge with some really high potential, maybe younger, but not always younger, people of color who would love an opportunity to advance their career in healthcare or otherwise. And with this conversation about workforce development, maybe there's some intrigue around when organizations identify people who really have high potential, could we as a community help those people advance together? I know we do that as individual organizations, but we all struggle with diversity in our overall workforce. And so maybe there's something to play with there, maybe there's not, but is there a way to partner in identifying folks who want exposure, want experience? Maybe they can rotate through various partner organizations. Just a thought about if we have collective goals in this area, how do we act collectively? So just a thought.
Dan, I think that's really powerful. And I didn't want to go too far into it, but so one of the business lines that we have at COIC is that we have youth education and training, and part of that training is under the Workforce Investment Act, and it's in coordination with our EC Works, which is our Workforce Investment Board. And we have been doing some internships between Warm Springs and the Public Health Office in Jefferson County. And, as I think about some of these, how do you get it rolling? It's you maybe start small and then grow from there. And might there be some ways that, we can engage in a smaller cohort of ideas in, building this network that you're talking about so that we can address some of these challenges, and whether that's utilizing our alternative education programs and the youth that we come into contact with, which is 16 to 24-year-olds. It really feels like there's a synergy here of that youth side, obviously not as broad as what Miguel is outlining, but there might be some synergies of existing funds to be able to do some pilot.
Cool. Thanks, Tammy.
Other comments or thoughts on that? Because then we're going to move on to world peace. So many things for us to work on.
The only comment I would have about it is that for those of you who aren't Rotarians, Rotary International is putting specific emphasis on DEI improvement and addressing and being a part of the solution. So think creatively as you go down the planning horizon. If you hit a bump and say, how can the community be involved? There are a lot of people around this issue that want to do something meaningful, but they don't have a way to do it.
That sounds like an open door. Go ahead, Rick.
Yeah, and we have this embedded in our personnel policies, and we pay for a lot of training and schooling, because it's the only way we really can get a workforce that looks like our communities and comes from our communities. Otherwise, they're not in the workforce. One of the things that's really important is many of these people have no role models, and how to function and how to be in a professional society in Central Oregon that is overwhelmingly white and middle class is really becomes at some point very challenging for folks, and sort of at a level of identity. And so I would encourage, it's not just paying for stuff and creating the opportunity, but creating a support network of folks who can figure out how to negotiate things. Someone like me from a doctor's neighborhood in Salem, Oregon, it was like friggin' handed it to me. This is like easy. But if you don't have all those sets of privileges handed to you, it's can be a big jump for folks.
Brad, did you go right ahead?
Yeah, probably made this point before, but there's also, I've definitely made it with the workforce board and the group that, I think Miguel's still a part of that, but it was the East Cascades Works, St. Charles, and I'm not sure who else. But we need to remove the barriers for immigrants in our communities who already have that training and experience, and either offer waivers or find a way to, I know people in our community that are either not working at all because they don't have permission to work, or they're doing something like working in a restaurant or cleaning houses or hotel rooms, and yet they have a degree and experience in nursing or whatever it is. But in nursing in particular, I know a few people, and it's unfortunate. That's a resource right there. We just need to remove barriers. So I want to raise that up to keep it in mind, and we're going to keep working on that.
Excellent. Thank you, Brad. Well, more work on the horizon. I love the discussion, and this is sort of our collective thoughts together to solving issues. So thank you, everyone. So with that, unless anyone has anything else to bring before the board, we will adjourn, and we'll see everyone bright and early on the 15th. Okay. Make it a great day.
Bye, everyone.